benign thoracic surgery. We've got quite a few very good presentations, and on behalf of my co-chairs, I'd like to welcome you to this session. I'd request all presenters to stick to the time, and then there will be a Q&A session at the end of the presentation for three minutes, and we shall take it in turn. Hopefully everything goes perfect. We've had some gremlins creep in. So the first presentation is by Ben Shanahan, and I'd like to welcome him to present on the presentation, which is to develop, implement, and evaluate an integrated care pathway for patients presenting with pneumothorax. So Ben, off you go, please.
I am delighted to be here on behalf of Professor Redmond and our team to present our experience developing, implementing, and evaluating an integrated care pathway for pneumothorax patients. Pneumothorax is a common clinical entity and accounts for about 7,000 bed days in Ireland per year. There is significant variation in management across different clinical sites, and with inpatient bed capacity an ever-present issue in the publicly funded healthcare system, we set out to develop an integrated care pathway that maximised ambulatory care for suitable patients, and as such to reduce the economic burden of pneumothorax on the healthcare system. There is robust evidence internationally that ambulatory care for pneumothorax is feasible and safe, and there is provision made for it in the BTS guidelines. We performed a systematic review of the literature, and we determined the mean success of ambulatory care to be 72% across 17 different studies. We developed an integrated care pathway with reference made to existing BTS and ACCP guidelines, and then refined the pathway using a modified Delphi technique. We evaluated the pathway with a multi-site prospective observational trial specifically designed to evaluate the economic impact of pathway implementation. Control data for length of stay was obtained from HYPE, which is national level discharge data in Ireland. The pneumothorax outpatient clinic was ANP-led where feasible. Primary endpoint was total length of stay in the first 30 days following a pneumothorax event. Secondary endpoints included self-reported patient quality of life scores, pain scores, requirement for a second intervention, and complications related to device insertion. We determined that approximately 30 patients would need to be recruited to detect a clinically significant difference of 1.5 days, with a statistical power set at 0.8. This was the integrated care pathway as it was used in the study. This served as a decision support tool for clinicians, a clinical record, and also as a data collection tool for the study. Those patients who received, if you like, the main intervention in this study were the primary spontaneous pneumothorax who proceeded down the leftmost column, and that is those patients who had a drain inserted at the emergency department and were discharged with drain in situ with return to the pneumothorax outpatient clinic, that ANP-led pneumothorax outpatient clinic, a few days later. However, we provided clinical guidance on management of all pneumothorax types, and indeed we enrolled patients with all different types of pneumothoraces. We recruited 32 patients. There was a bimodal age distribution, as would be expected with pneumothorax. The most important table of the entire presentation is here on the top right, and that is to say that the mean length of stay that we observed following implementation of the ICP was 4.56 days, and this was across all pneumothorax patients, not just those who were discharged with drain in situ. The mean length of stay in the control, or the HYPE mean length of stay, was 7.4 days. And so we had a statistically significant reduction in length of stay following implementation of the ICP with a p-value of 0.001. The subgroup breakdown in terms of length of stay is presented on the left. And as you would expect, a secondary spontaneous pneumothorax patients had a much longer length of stay, while the primary spontaneous pneumothorax patients who were treated conservatively had a very short length of stay of less than 1 day. Unfortunately, subgroup analysis wasn't possible for all of the different subgroups. In terms of the quality of life data, we use the EQ5D5L instrument, and this instrument records a summary crude score and also a visual analog scale score. And there was statistically significant reduction in both of these metrics when the patients observed as part of the trial were compared to the standard healthy population. There was a gradual decrease in self-reported pain for the 5 days following drain insertion, as would be expected. There were no complications related to drain insertion at the study sites. 8 patients underwent surgery in the 30-day time horizon, and the mean time to surgery was 5.3 days. 2 patients underwent a second intervention. In terms of a discussion then, implementation of an integrated care pathway with focus on ambulatory care is feasible and safe, and we have demonstrated that it results in a reduction in inpatient length of stay for pneumothorax patients. This translates to a cost difference or an incremental cost reduction in treating a patient according to the pneumothorax ICP of €2,314 per patient. And this applies to all patients, not just those discharged with drain in situ. Nationally, this represents greater than a €2 million cost saving. In terms of limitations, we recognize that there was already probably an ERAS culture at the trial sites and therefore already a culture of discharging patients with drain in situ. We also acknowledge the existing questions around the accuracy and validity of HYPE data. However, we contend it was the best control data available to us. In the future, we would like to see this program implemented nationally, and we would reinforce the importance of an advanced nurse practitioner in establishing and maintaining a program such as this. Thank you very much.
Thank you, Ben. That's an excellent presentation. I'd like to now invite members of the audience for questions, please. Right. We got only one question so far. So, Lubna Bakar says that, do you think the exam will focus on either the cardiac or thoracic surgery in future? I think that's the wrong room you've got. What we should do is, Ben, we might just bring you back later because I think we had some problems with the question answer. So we might bring you back later from some questions. If there are more questions, that's okay with you.
Great, yeah, that'll be fine. Thanks very much.
Thank you. Okay, so I'd like to invite some of my co-chairs to introduce the next presentation, please. Joe. Sorry.
Can you see me?
Yeah, Joe, that's great. So
the next paper is a presentation on improved survival after chest wall reconstruction following major trauma. Boo, do you want to get started on that? I'm not sure if I've got your full name on that.
We'd like to thank the Society for inviting us to present the findings of our study into the impact of chest wall reconstruction following major trauma. Polytrauma is associated with major thoracic injury in 35% of cases. When the severity of injury is significant, the mortality may be in excess of 20%. In 2007, in the United Kingdom, there were 5,400 deaths. The UK government at this point determined that there was a need to reduce the percentage mortality by approximately 20% and therefore introduced the strategy of major trauma centres. Our institute became a major trauma centre in 2012, and we introduced chest wall reconstruction as part of an evolving policy in September 2014. We have evaluated the outcome following chest wall reconstruction from this time to the end of December 2019, comparing it to those patients who have had major chest wall trauma and have not required fixation. The study group has been between the age of 16 and 19, and a number of exclusion criteria were applied. The total number of cases with major trauma admitted to our institute was approximating 8,400, of which 28% had suffered thoracic trauma. Major chest trauma accounted for 1,296. Our study cohort was 947, of whom 157, 16.6%, underwent chest wall reconstruction. Our classification of flail chest is shown on the right-hand side. Over this interval, there was an increase in the number of patients admitted with major chest trauma. The pink bars represent those who have not been fixed, showing an increasing number to 2017 and then subsequently a steady rate. The blue bars represent minor chest wall injury, and the green bars show that initially there was a steady state for fixation, but in the latter years there has been an increased number of patients receiving chest wall reconstruction. The right graph shows that those receiving chest wall reconstruction have the highest severity of injury. We've compared non-chest wall reconstruction, non-CWR, to CWR patients as shown in these two columns, and we found there are differences between the groups. The CWR patients had a higher incidence of comorbidity, yet non-CWR a higher incidence of polytrauma. Yet CWR patients and non-CWR patients had an equivalent total injury score, with a tendency to a higher score in the CWR patients. CWR patients did, however, have a higher chest AIS and rib AIS. Likewise, they also had a higher incidence of complications following injury, pneumohemothorax, bony injury, and pulmonary contusion, yet the non-CWR patients had a higher incidence of head injury. The demand for intensive care treatment was higher in the CWR group, a greater number requiring critical care admission, requiring ventilation, prolonged ventilation, and also a greater number stayed a longer period in hospital. Yet the mortality was significantly reduced. 6 patients died, a percentage of 3.8%, as compared to 8.6%, a significant reduction in mortality. Clearly, there are differences between the groups, so we've sought to correct for covariates that it might impact on the mortality, and a number of factors, including COPD, ventilation status, and head injury impact on these. Yet, CWR has a positive impact, reducing the mortality with a hazard ratio of 0.4. We tested this in a multivariate Cox multivariable model, which has demonstrated that this finding is robust, the hazard ratio being 0.37. We therefore have concluded that chest wall reconstruction reduces mortality after major chest wall trauma. The 60% reduction in mortality exceeds the government target of 20%. We suggest that CWR should be applied to a broader number of patients. Thank you.
Go ahead. Right. So I think we lost Joe's voice, but I've got a question from Kieran for Chris. Kieran asked about selection bias towards sicker patients. Chris, go ahead.
So the video is still running.
Not here.
Sorry, can you place that question again?
So
the video is still running on mine.
Well, just go ahead and answer the question. I mean, Kieran says, could you ask? He asked about selection bias towards sicker patients.
Yeah, largely we have selected sicker patients, but most of the patients that we've chosen are the sicker patients, and therefore, listen, I think the presentation's still running.
No, it's not. Can I assure you it's not?
Right, okay, just it's running on mine. I can still hear it on mine.
We can hear you perfectly.
Okay. No, so we've done quite a lot of studies. So we've looked at the possibility of selection bias, and there are a couple of areas of bias that we have. One of the bias is that the patients we've chosen to operate on have a slightly higher incidence of comorbidity. We do know also that their injury scores are significantly more severe than the groups that we haven't operated on. And yet, despite that bias, we still get much improved survival. So it's a 60% reduction in survival risk. when we've tested on multivariate analysis. So yeah, there is bias, but it's bias in that we've picked the higher risk group of patients.
Right. Thank you, Chris. I think, so Louise, would you mind introducing Chris's presentation again, please?
Yeah, so next presentation, we keep with Chris Sutter, and is an interesting prospective preparative study about the pectus carinatum causing disturbance of exercise function. Go ahead, Chris.
We'd like to thank you for the opportunity of presenting our findings in regard to exercise dysfunction in patients with pectus carinatum. Pectus carinatum is significantly less common than pectus excavatum. Its prevalence is between 0.3% and 0.7%. Though commonly considered to be primarily a cosmetic problem, Knudsen reported that up to 86% of patients have a form of exercise dysfunction, including shortness of breath and tiredness. We sought to investigate the incidence of exercise dysfunction in patients who we have treated with severe pectus carinatum. Standardized preoperative investigations were performed: CT scan, pulmonary function tests, and cardiopulmonary exercise tests. We've undertaken cohort and subgroup analysis. The subgroups defined by a VO2 max above 80%, i.e. the normal VO2 max group, or below 80%, the low VO2 max group. The demographic characteristics of the 9 patients were that they were a mean age of 17 years, their height was 177 centimeters, and their weight 58 kilograms. The Haller's index was 1.68. Evaluating cohort pulmonary function tests demonstrated that effectively the pulmonary function tests were normal. That is, FEV1, FVC approximated 100%, and the vital capacity and IC were also within normal range. Looking at the outcome data of the cardiopulmonary exercise tests, the group achieved a significant RER, well above 1.1, but also significantly above reference values. The VO2 max, however, was reduced to just above 80%. The O2 pulse was also reduced, and the breathing reserve of the cohort was also elevated, showing unused lung function. If we look at subgroup analysis, we find that both groups engaged intensively in exercise, achieving a significant acidosis during exercise. However, the normal VO2 max group achieved a significantly lower pH and lower bicarbonate, with an increased lactate indicating a greater degree of acidosis, whilst the LVO group achieved a higher RER, though not significantly, during exercise. Comparison of outcome data shows that naturally the LVO group had a VO2 max group value below that of the NVO group. However, the work achieved was also reduced, the O2 pulse was reduced, and breathing reserve was significantly elevated, as was the VT-IC ratio. This indicates that they have greater degree of ventilation and cardiac dysfunction. If we look at plots obtained during cardiopulmonary exercise test, looking at an example patient with a normal VO2 max and an example patient with low VO2 max, we find that the normal VO2 max patient achieves a lower RER, in other words, a lower CO2 to oxygen ratio, and their ventilation appears to be significantly better and more efficient than the similar group demonstrated below, who have a higher RER of 1.4, and the ventilation characteristics, as demonstrated by the curve on the bottom right, is significantly reduced. Examining for predictors of VO2 max, we find that VT-IC ratio and ventilation characteristics, either breathing reserve or minute ventilation, are all directly related to the VO2 max that is achieved. Therefore, ventilatory dysfunction is the primary determinant of exercise dysfunction.
we would like to conclude that pectus carinatum is associated with disturbed exercise function and exercise physiology in 44% of cases. The reduced VO2 max is demonstrated to be causally related to compromised ventilation. Normal VO2 max achieves a higher and greater degree of acidosis, but we believe that this is maybe resulting from compensation by improved ventilation. Thank you.
Hello. Can't hear anyone now.
There's a question coming in which asks from Kieran, are these children unfit because they avoid exercise? That's a misconception that's commonly put forward, and which is why we've looked at the level of exercise that they undertake. And we've also looked at ventilation characteristics, and the problem with the whole issue of pectus carinatum, pectus excavatum, is that everyone assumes because these children or young adults underperform, that they are lazy. But in fact, the RER demonstrates that they're actually exercising to a much higher level, of exercise than the normal population. And also the lack of ventilation demonstrates that this group of children have got compromised ventilation. And that's the point of the study. They're not lazy, they're actually working much harder, and there are a number of characteristics, the acid level of acidosis, etc., are all higher than control values. And it makes sense because in pectus carinatum, the chest is hyperinflated. So if we had a COPD patient with a hyperinflated chest and they said they can't breathe, we wouldn't disbelieve them. But we do disbelieve it because it's a child and we've got a mindset that this is purely cosmetic.
Thank you, Chris. I don't think there are any other questions at the minute from our room. So I'd like to invite you back again, Chris, for the next presentation, which happens to be yours as well, which is VO2 max inadequately defined severity of exercise dysfunction of pectus excavatum. Chris, please go ahead.
Thank you.
We'd like to thank the Society for inviting us to present the findings of our study that have investigated the exercise dysfunction of patients experiencing pectus excavatum with cardiopulmonary exercise test evaluation. Most patients with pectus excavatum are reported to experience a degree of exercise dysfunction. A number of major international studies have attempted to demonstrate the benefit of surgical treatment using VO2 max before and after surgical treatment. However, the values obtained before surgical treatment were often within the normal range as they were after. NHS England have deemed that the results obtained were inadequate to support continued funding for surgical treatment. We undertook this study to evaluate whether there is a group of patients who have an abnormal exercise profile as deemed by cardiopulmonary exercise tests. We looked at our patients who we treated since 2006, and each of the patients were investigated by a standardized protocol of CT scan, pulmonary function tests, and cardiopulmonary function exercise tests. We've included in this study only those patients who achieved a good level of exercise as evaluated by RER of 1.1. Subgroup analysis has looked at those patients with a normal VO2 max above 80% predicted and a low VO2 max below 80%. Cohort analysis of VO2 max identified the mean value was 78%, slightly below the lower limit of normal of 80%. The work achieved was 88%. However, if we look at the dot plot graph, we find that 53% of the cohort did not achieve a normal value of VO2 max. This formed the group of LVO 53%. If we compare their demographic data, they were similar for age, gender, height, and weight. Likewise, the Haller's index for both groups was similar, as was the pulmonary function tests. If we look at the metabolic characteristics, both groups achieved a significant acidosis during exercise. However, the NVO group achieved a greater degree of acidosis with a lower pH, lower bicarbonate, and higher lactate. Both groups, however, experienced significant CO2 retention during exercise, almost 70% showing elevated CO2 at the end of exercise. Comparison of the outcome values of the CPET test indicated naturally that the LVO group had a lower VO2 max. However, the work, the anaerobic threshold, and O2 pulse were all reduced, but the breathing reserve was elevated, showing that the LVO group experienced significant compromise of cardiac and ventilation function during exercise. If we examine this further, looking at the incidence of abnormal measurements in the group, we find that the LVO in blue all had a higher incidence of abnormal parameters of CPET, that is of work, anaerobic threshold, and O2 pulse. However, both groups, subgroups, had abnormal ventilation, as demonstrated by an elevated breathing reserve or elevated end-tidal CO2. If we compare the total number of abnormal factors in both groups, however, the NVO group primarily only have a single abnormal parameter in 80% of patients, yet the LVO group have over 75% of patients experiencing 3 or 4 abnormal parameters of exercise at peak exercise. In conclusion, we would suggest that cohort mean values of VO2 max miss exercise dysfunction in at least 50% of patients with pectus excavatum. There is a need to use delineated VO2 max to differentiate the severity of exercise dysfunction, and there is a need to use delineated VO2 max for future comparative treatment studies. Thank you.
Thank you, Chris. We already got a question from our star audience, Kieran. Kieran asks, how do you explain how Cody Miller won a gold medal in the 100-meter swim relay for USA at Rio Olympics with a severe excavatum deformity?
Interesting question. As the data has clearly shown, some people have a high performance. So there are some people with a VO2 max which is 120%. There are others who have a VO2 max which is 60%. And so we can't assume everyone's the same. And we don't do this with other conditions. If you have rheumatoid arthritis, you're identified as the problem that causes you problem. Likewise, if you've got coronary artery disease, we find out what causes you problem. We have to do the same with pectus excavatum. They're not one group of patients. We have to delineate them, we have to identify the ones with problems, and we have to treat them. Now, I've got patients who have dysphagia from the problem. I have patients who have syncope 2 and 3 times a day. There are patients who are really severe, and I've got patients who can't walk 10 or 20 yards, who after correction of the defect, they can walk really well. So it's important that we do not treat the group as one group, because that's the reason NHS England have withdrawn funding from us, because we treat it as one cohort. And the reason for doing this study is to identify the group of patients who actually have a problem and aim to treat that group of a problem so that we can get re-established funding in England for the treatment of these patients. If we don't identify the ones with the problems, NHS England's not going to turn round.
Thank you very much for that, Chris. I think that's a very important point because I still, since they've stopped the funding, I still get patients who, desperate for it. And many of them, we've never routinely actually done CPEXs or any other exercise limitation on our patients. I mean, psychologically, we've tested them, but that's a very important thing. Maybe we should consider. I mean, are you considering sort of leading a national effort or joining the national effort with the exercise limitation aspect?
Yeah, we're just formulating NIHR grant to look at this, but the problem is trying to get the funding to do this. But we're wanting to invite a number of centres to join us on this. But it is a comparative study because currently only Wales and Scotland have the funding to treat, so we'd have to look at that. But one of the problems we've got in the UK is we haven't measured the problem. And so we don't have data, but I've been doing this routinely for every patient. So I've got the data for every patient, and we need to look at it. And the other problem is that people assume that if you measure VO2 max, you have the answer. And the published literature clearly shows that's not the case. So the North American study and the Danish study, which have just looked at the whole group and VO2 max of the whole group, come out with values that are normal before and after surgical treatment, which has not helped the case for the patient. So we need to stop and say, well, which groups are really having problems, or what is the subgroup analysis on the outcomes of treatment? But we've got to have measures for this, because NHS England has told us, you've produced no data, you can't have the funding. We have to turn this around and get the data together. Yeah, we are trying to get a national group together to do that.
No, I mean, that's great. And I'm sure myself and my colleagues would like to join in that effort. And so thank you very much for all the presentations. I would like to also invite you now to invite the next presentation, please, Chris.
Thank you. So we're going to have a presentation on a relatively rare problem, and one that I think is underdiagnosed, slipping rib syndrome. So it's great to have a presentation on that from Gothanans Santhikuraman. Welcome to the stage.
Good morning to the conference attendees, members of the panel, and to the chair. I present to you our protocol for the management of slipping rib syndrome and a single institution perspective and case series. Slipping rib syndrome is commonly an overlooked and underdiagnosed cause for lower anterior chest wall pain. Commonly affects young adults, more often younger females than that of males, and particularly with a background of being otherwise fit and healthy. The real prevalence is unknown because of its underdiagnosis. The underlying pathology is thought to be mechanical in nature, secondary to the hypermobility of the 8th to the 10th rib, causing the rib, more specifically the cartilaginous tip, conflicting with the rib above. This in turn impinges the superior neovascular bundle and resulting in this painful and debilitating syndrome. Traditionally, a hooking maneuver is performed on the patient to demonstrate the increased mobility of the affected rib and reproducing the pain, as illustrated by the video in the bottom right-hand corner. Recent studies of slipping rib syndrome, particularly from North America, has highlighted the use of dynamic ultrasound of the chest wall as an important tool for diagnosing this condition confidently. Dynamic ultrasound scan of the chest wall can illustrate the excursion of the rib superiorly with conflict to the rib above, as shown in the ultrasound image on the top right-hand corner. We highlight the neurovascular bundle on the lower left image, and by performing the twisting movement, it illustrates intercostal nerve impingement, which is also confirmed by reproduction of the pain by the patient, as illustrated by the bottom right-hand image. So therefore, we aim to evaluate the use of dynamic ultrasound scan as a part of a reproducible protocol for slipping rib patients on outcomes following surgical intervention. It was a single center retrospective review of 7 patients between September 2019 to September 2020. And here we had a review of outcomes in consecutive patients who underwent surgical excision of targeted rib tip excision following a standardized protocol. Primary outcomes, amongst other data points, consisted of improvement of symptoms and reintervention and complication rate. The image here illustrates the intraoperative imaging of a surgical excision of a chondral tip. The protocol outlined here shows, following as a referral to a thoracic surgery service after review and slipping rib is suspected, a dynamic ultrasound scan by a dedicated musculoskeletal radiologist is performed. depending on the patient choice, they can either have an injection with steroid and local anesthetic, which tends to give them temporary relief, and then review, or go straight for surgical intervention via condylar rib excision with or without rib stabilization. We then follow these patients up on a 6-week and 3-month post-op basis. Our results showed a patient cohort similar to that commonly described. All were chronic users of analgesia, varying from simple to moderate, ranging from 2 to 8-year history prior to referral. The diagram illustrates where the patient presented with the pain. As you can see, anterior chest wall pain was common on either side around the costal margin. Prior to review, all patients had multiple imaging modalities, including CT, MRI, and even a diagnostic laparoscopy, which added no value to the diagnostic pathway. However, dynamic ultrasound, on the other hand, consistently produced rib conflict findings, confirming slipping rib syndrome. 3 patients had opted for the injection, with temporary relief ranging from 1 to 6 weeks, and all eventually had surgical excision of the targeted rib. The pie chart here shows that 86% of patients had successfully had partial or complete resolution of their symptoms. And therefore, in conclusion, dynamic ultrasound scan has added diagnostic value, but also allowed for targeted excision of the pathological rib, with 6 out of 7 patients displaying improvement. The protocol developed in collaboration with musculoskeletal radiologists highlights adjunct dynamic ultrasound scans can allow temporary relief with steroid injections, but also targeted chondral rib excision may offer longer-term successful outcomes with or without rib stabilization. In the near future, we will be publishing a larger case series with collagen data pre and post intervention. The current data set to mention was limited due to the current COVID-19 pandemic, which reduced our elective surgical activity in our unit considerably. Thank you very much, and I'll invite any questions.
Hi.
Hello.
Can you hear? Great presentation. Thanks very much. This is a rare condition. I've seen it about 7 times. A couple of questions. Do you think this is part of a spectrum of problems that includes distraction of the costochondral junction, which can lead to intercostal herniation, or do you think slipping rib syndrome is an isolated condition by itself?
Sure, so it's a very good point. So in terms of slipping rib syndrome, looking at the incidence, it's fairly rare, but also underdiagnosed. They probably say in the GP literature, about 20% of patients can have an element of the pathology of slipping rib syndrome during their lifetime, but only a few of them actually have the severe and persistent pain. Now, the actual reasons why they present with these symptoms vary. So some have trauma to the chest, causing this disruption, and then having after 4 or 5 years coming to the thoracic surgeon having this diagnosed. But some who are quite young, 12, 13 years old, who actually have this kind of congenital causative factor, which could have a major part in this. So therefore, it's not completely clear at the moment in terms of whether it's an acquired or congenital attribute. But the fact that 20% of the population have this sort of pathology makes you think that it's a kind of a mixed bag of congenital plus acquired.
Jonathan Edwards has come in and says, you've used excision as the surgical technique. I use a different technique. I presume Jonathan Edwards also uses one, because he asks, do you cause instability by resecting the end of the 8th or 9th cartilage?
So I'm assuming it's referring to the other technique of rib stabilization, which yes, Dr. Hansen in West Virginia has kind of promoted and shown good results for. I think in terms of, because we had a small cohort of patients, and we found actually by excising the chondral tip that out of the 6 patients who had good resolution, they didn't have further pain. So therefore, you would be assuming that it didn't cause further instability. The one patient that did continue to have chronic pain wasn't actually due to the instability, but was actually due to the fact that not enough of the chondral tip was actually resected, and therefore there was still a conflict on a repeat or dynamic ultrasound. But obviously, with a bigger cohort of patients, we can then identify whether the stability would be something we can offer. And as you know, that these patients, highly research these slipping rib syndrome, know both techniques, and sometimes it's based on patient preference as well. Some patients are very keen on the rib stabilization technique because after 6-7 years of this pain, they kind of reached the end of their tether, and therefore, in our recent study that we're going to be publishing, you will see that we have a mixture of techniques, and we'll be able to evaluate further from there.
And just from my point of view, I find that if you fix and stabilize that doesn't always get rid of the pain. So I think often the pain remains there. So that's just my personal view. And does the ultrasound, are you able, Kieran McManus wants to ask, are you able to differentiate instability of the joint and subluxation with ultrasound or not?
In terms of instability of the joint, yes. So the ultrasound, because it's performed by musculoskeletal radiologists, they perform dynamic ultrasounds in all parts of the body and specifically joints, and so they're very able to differentiate not only in terms of instability, and also joint disruption, but also fractures and a disruption within the bony element itself. So therefore, it gives you a multitude of data. And therefore, it goes from a clinical diagnosis, which can be subjective and interpreted in different ways, to a objective diagnosis, which is something which, kind of revolutionizes how we treat slipping rib.
Brilliant. All right. Thanks very much indeed. Great presentation. Thanks for submitting this to SCTS.
Thank you.
Louise, over to you.
I thought it was me.
Oh, Joe, sorry.
Yeah.
Joe, carry on.
Yeah, is that okay? Yeah, all right. So we've all experienced admissions under us for rib fractures as thoracic surgeons, and quite a few of them are old and they linger on our wards. I know the Leicester team have done a fair bit of work using the Stumble scoring system. So Karishma Chandarana is going to present on predicting mobility in rib fractures. Do the old and frail stumble? Over to you, Karishma.
So hello everyone, my name is Karishma. I'm a trainee in the East Midlands, and today I'm going to be presenting some of the work we've done in collaboration with our allied healthcare professionals, titled Predicting Morbidity in Rib Fracture Patients, Do the Old and Frail Stumble? So, the assessment of frailty is a hot and popular topic, with a greater number of older patients now than ever before, and a number of these living with the condition that is frailty. Rib fractures are associated with significant morbidity and mortality, particularly in this cohort of patients. The Stumble screening tool has been developed for use in an ED setting, with the aim of informing discharge decisions and the level of care required for these patients, either to be admitted as an inpatient or discharged home with safety net advice and analgesia. So this is the Stumble tool, and it's a risk scoring tool that's used to predict the probability of complications and then influence management in these patients. So as I said previously, the patients could be discharged home with safety net advice or analgesia, or if they are admitted, it's where they're admitted and the level of care they receive. The Stumble tool is made up of 5 components: age, number of rib fractures, pre-injury anticoagulants, chronic lung disease, and oxygen saturation levels on admission. So the score is calculated from these 5 things, and then the patients are categorised into 3 groups: a low-risk group where they can be discharged home, an intermediate group where they should be admitted to a ward-based setting, or a high-risk group where they should be considered for ITU management. So risk models are important because they are used to guide patient outcomes. They allow a common ground for clinician discussion and actually can help in prognostication. So what we wanted to do was assess the predictive value of the Stumble tool in the required setting for patients managed under the care of a specialist thoracic team. So We included all patients in the year of 2018 that were admitted to thoracic surgery with rib fractures on a prospectively maintained database. And additional to our usual data collection, a physiotherapist on their first contact would calculate a stumble score. We collected extra data from the patient imaging and also their electronic case records, and we did all our data analysis using Stata. So just analysing our own cohort, we found that we had 78 patients, of which the majority were male, with an average age of 67. Mechanical fall was the most common mechanism of injury by far, with an average number of 4 ribs fractured. 45% of patients needed a chest drain on the ward, either for a hemothorax or a pneumothorax, and 10% of patients underwent surgical intervention. This was either rib fixation or drainage of hemothorax. The majority of our patients received physiotherapy input, and the average length of hospital stay was 5 days. So if we look at our results compared to the stumble tool, the majority of our cohort fit into that middle section where they have a score between 12 and 26 and should be managed according to stumble in a ward-based setting. It says that 2 of our patients were actually able to be discharged home with analgesia and safety net advice. However, these were cared for on a thoracic specialist unit. It says that 17 patients should have been considered for ITU. However, this is a large overprediction, as only two of our patients, which is 5%, ended up needing ITU, and 3 needing HDU, which is significantly lower than that suggested by stumble. So overall, the stumble screening tool correctly predicts the highest level of care in 73% of our patients, but overestimates the care requirement in 22% of these, as well as underestimating the requirements in 5%. So if we were to plot the different things such as age, clinical frailty score, and the stumble score on a ROC curve, the stumble score actually comes out best for ITU admission and failure to return to activities of daily living. However, given that we have such a small number of patients and events and large confidence intervals, it's difficult to draw any hard conclusions from this. So overall, the stumble screening tool has moderate clinical value in informing the level of care required for patients admitted for rib fracture management within a specialist thoracic unit. And overall, when our patients trip and fall, our prognostic methods stumble. Thank you so much for listening, and if you've got any questions, please feel free to email me on karishma93@hotmail.com.
One then. Can you hear me?
Yeah, I can hear you. Can you hear me?
So I was just going to ask, the one where they were deemed as high risk, would you routinely get them assessed by intensive care, or would you do anything differently for them than you would do for the other group of patients? Thank you.
So interestingly, the rib fracture performer is put together by our A&E department, which is actually at a different hospital. And so on that performer, it says anyone who is deemed high risk on that performer, not necessarily by the stumble tool, should be assessed for ITU. I think when subjectively the patient looks a little bit more unwell or might require a bit more input, they are escalated to the outreach team from ITU, and if they feel that they need discussion at ITU, they pass that on, unless they're more unwell and need immediate treatment, by all means, then we will refer. The ones that went to ITU from our sample were because they ended up needing drainage of hemothorax in the middle of the night, and actually it was probably a safer place to put them during that time, as opposed to them needing extra support as such.
Okay.
Can I have a question?
Sure.
Karishma, I work in UHW in Coventry, so we are a large trauma center. We're trying to refresh our guidelines. Do you think the number of fractures gives more risk of mortality or morbidity? Because I have this ongoing discussion. You know, if you have a old patient with osteoporosis, she fell from a small high and she will fracture 6 ribs. And if you have a young kid and with 1 rib fracture, is a very severe trauma. So you take this in consideration, and what do you think about the number of fractures has a risk of morbidity and mortality?
Yeah, that's a really good question, and I think we come from quite different units because at Leicester we're not a trauma centre at all. So anything that comes to us are probably at lower risk compared to what gets transferred to the trauma centres in our area. We didn't find when we analysed the data that the number of ribs were associated with higher levels of care or a longer hospital stay. However, we only had 3 patients that underwent rib fixation, so the numbers are very, very small, and we can't say that it was associated with the number of ribs that were fractured. And we didn't find any difference in the number of flail chests and how many we operated on. But again, like I said, we've got very small numbers here, and probably have a very different cohort of patients compared to what you guys do there.
Karishma, John Edwards has commented, and I was just going to comment as well. Do you think the risk, the score actually over predicts the higher age group? In other words, for a thoracic ward, and if you're going to be admitting patients on the stumble score itself, isn't there a risk that you're going to be admitting too many people just on an age criteria alone, rather than the severity of injury?
Yeah, definitely. I think what we find is we get a lot of pressure from our A&E departments to admit patients based on a number of their comorbidities as opposed to actual like an actual deficit caused from the rib fractures. And that's what we find, that if we were going by the stumble score, we were admitting more patients essentially. But I don't know if those patients needed to be assessed by a thoracic surgeon, because all our patients were. So they were all transferred across. They all received an assessment by a thoracic surgeon, by our physiotherapy team, which are specialist respiratory physiotherapists. Some were referred to our occupational therapists, and then we followed them all up in an outpatient clinic based on our local guidelines of what should be referred to thoracic surgery. But again, I think our guidelines as well need refining, and I think we looked at the stumble tool to see if it's something that we could use in our practice, but it does overpredict a lot of the care our patients need.
Lovely. We're going to have to move on at this point. Thanks very much for that, Karishma. That's really good, really helpful for future studies.
Thank you.
Yeah.
Lovely. Okay, who's presenting the next one?
So we keep with the next presentation. Still one of the hot topics in our current practice is Karen McManus, and the topic is chest wall stabilization facilities return to manual labor. Go ahead, Karen.
The randomized trials into rib fixation that we're also familiar with have concentrated mainly on intensive care unit stay. Tanaka did look at return to work, but Marasco was rather pessimistic about getting Australians returned to work. Because of my extensive experience in personal injury claims, I've developed a specific interest in return to work. Of the 1,100 patients whom I've examined over nearly 30 years, half had chest injuries severe enough to warrant trauma centre admission, and these form the basis for the analysis that I will present. I do have to declare a pecuniary interest in that all patients have paid for the best possible report. One could also say that many of these patients had an interest in not going back to work. However, the cross-section of patients is similar in both cohorts, and many of the fixation patients also had personal injury claims. When we look at the pre-injury status on the left compared to the post-injury status along the top, Even following severe injuries, 76% of desk workers can return to work. However, only 7.8% of heavy manual laborers and 27.4% of light manual laborers return to their previous level of work. No one returned to repetitive heavy manual labor. Heavy manual laborers in particular had difficulty retraining for desk work, so many remained out of work in the long term. Of the whole group, only 2.7% returned to heavy labor and 22% to any manual labor. Between 2005 and 2019, a separate cohort of 67 chest injury patients underwent chest wall fixation. Excluding 11 who had late fixation for non-union and 2 sternal fractures, there were 54 with fixation for acute trauma. 64% were in ICU or HDU. Though the remaining 36% were on the ward, our thoracic ward is set up as a high dependency unit to treat our post-operative patients. 15 who were not in work prior to their injury and 2 who were unavailable for follow-up were excluded from analysis. Of those undergoing fixation, 24 out of 37, that's 64.9%, were able to return to work. 19 were able to return to manual labor, including 7 who were able to return to repetitive heavy manual labor. 3 of the desk workers were able to return to competitive sport. Comparing the whole group to the non-fixation group, 51.4% returned to manual labor and 27% returned to heavy manual labor. The commonest reasons for not returning to work were the consequences of head injuries or the consequences of major limb injuries, where the rib fixation was often done to help their rehabilitation to walking on crutches or a frame. But this being Belfast, some of them didn't turn up for follow-up. So in conclusion, in this highly selected group, surgical stabilization of rib fractures was associated with a higher rate of return to work, particularly manual labor, compared to a similar group to whom no surgery was offered. And the reasons that thoracic surgeons should be performing this surgery instead of orthopedic surgeons are shown in these images. Vats debridement of fractured ribs, placement of paravertebral catheter, drainage of hemothorax, muscle sparing incisions, repair of diaphragm. Thank you.
Hi there, Kieran. Thanks very much for that presentation. Really important, this topic, because currently the world out there still holds the views that, you know, you can do whatever you like to the chest wall and it doesn't affect the patient. Even people like Marasco in Australia, whilst she's published a great deal, seems to counter by saying it has no impact on patients. So this is a really important question, Kieran. Do you think it's just the fixation of the ribs and the gross instability caused by that, or do you think there's an element of unfixed clavicles as well? Because I just wonder if the two work together.
The clavicles are a big component of the ones that we got back to work. Now, this is a select group. I am biased towards those who were in manual labor beforehand, so I want to get them back to work. And those who've got a clavicle as well as the underlying ribs, they do very well. They're the ones we're getting back to repetitive manual labor. If you don't, none of them get back to manual labor. Now, I was actually discussing this with Savannah Marasco just at the Chest Wall Injury Society last month, and she finds that we're not using the right tools to compare people before and after. And you've got different aims when you're operating on different patients. Some you're just trying to get out of ICU. Some you're trying to get out of hospital. But I've concentrated very much on trying to get these ones back to work.
I would agree. John Edwards also calls the clavicle the 13th rib. We're trying to get a paper produced with a new classification that considers the chest wall as one whole rather than two lots of sets of ribs. And it emphasizes that the clavicle is important. And we are trying to bring in a pathway that collaborates the thoracic surgeons with the orthopedic surgeons to make sure the clavicles are fixed. Because we're finding the big thing people complain about after all of this is the clavicle. And that pain doesn't go away.
Yeah, we're quite fortunate that we've got some fairly specialist orthopedic surgeons on our site. You have to get the specialist orthopedic surgeons, not just the general orthopedic surgeons, the ones who have an interest in the shoulder. They understand this.
Yeah, and there are publications out there which should have changed the field now. So clavicular fracture should be vital to this group. Thanks very much. A really important presentation. Any other questions out there? I think this is, Jonathan emphasizes again the importance of a pathway that includes the thoracic fixation as well as the orthopedic. And this is a changing field, isn't it, Kieran, that we need to emphasize new pathways for managing these patients.
Yes, I was trying to say there are different aims with different patients, and this is what's clouded the whole field. We've tried to use very generalized instruments like SF-36 and so on to try and work out who benefits from this operation. But there are some patients who, even in ICU, you don't know what is their head injury going to be like. Even some that have minor head injuries in ICU, they turn out to have long-term deficits and won't get back to work. The HGV driver who won't get his license back. But then there's others who have quite severe head injuries who surprise you by getting back to work.
Nilanjan, you've got a question.
Hi. Yeah. So we got an audience question next from Adrian Marchbank. Could it be that earlier mobilization post SSRF predicts better final outcome? Kieran.
If you follow Piracci's sort of protocols, making sure that you assess people quickly, operate quickly. If you're going to operate, you're going to get the best results if you can do it in the first 48 hours. And I think that does affect the psychology of the patient and everyone who's treating them. Because if you stabilize that core and get the patient onto their crutches, mobilizing from their other injuries early on, they don't get that 2-week period where they get into complications and get stuck in bed. So I think, I haven't proven it, but I think it does make a difference to mobilize them early. Early mobilization has been the only real advance in thoracic surgery in the last 50 years and has been for the last 150 years.
Absolutely. Thank you very much, Kieran. I don't see any other questions on the... Let me just have a quick check. No, there aren't any other questions. So, Joe, would you mind introducing the next presentation, please? Thank you. Right. I think Joe's muted, so I'll go ahead. We got...
I'm muted.
You're unmuted, Joe.
Am I unmuted now?
Yeah,
okay.
Cool.
So I'd like to introduce Jonathan to talk about the SSI dashboard, and this is talking about post-operative wound infections following lung resection.
We have the pleasure to present our early experience of using the National Survey of Health and Development and the hospital episode statistics data for investigating postoperative wound infection following lung resection. We're considering postoperative surgical site infections following lung resection to be very important because they're potentially harmful for the patients and can lead to increased morbidity, mortality, and healthcare costs. The national SSI rate following lung resection was reported with 0.6% in a national benchmark audit in the GERFT issue in 2017. Our aim was therefore to develop a system for reporting SSI rates via dashboard. With the use of this dashboard, we were planning to examine trends in sepsis, VAC debridement, and mortality linked with the reported SSI as our 2 hospital sites to finally improve our practice. The SSI dashboard, which I will introduce to you during my presentation, is based on diagnostic and procedure codes collected from national surveys and episode statistics for the period of April 2010 to March 2018. Surgical site infections were included up to 30 days postoperatively. I will now introduce you to the user interface of the SSI dashboard. Our trust, the Roy Brompton and Harefield trust, is already selected here. I would choose the category of cardiothoracic surgery. And as we're interested in thoracic surgeries and side affections after lung resections, I would choose thoracic surgery, lung resections. This is how the dashboard looks and what it displays for the selected time periods. Coming back to my presentation, what we did next was comparing a 7-month prospective surveillance snapshot with around 400 patients done by trained surveillance personnel in our institutions with the SSI dashboard. We found that there was no significant difference between the SSI rates collected prospectively and the dashboard data. Both the dashboard and our snapshot data indicated a significant difference between the two hospital sites' overall surgical site infection rates. Similarly, there was a difference in coded VAC debridements, which you can see in the graph here, between the hospital sites, but there was no significant difference between the hospital sites for mortality, sepsis, and readmissions. To further investigate the reasons for these results, we found that in addition to difference in case mix, the difference between the two hospital sites' overall surgical site infection rates may be due to differences in interventions to reduce the risk of surgical site infection, especially the two different skin antiseptic solutions with, on the one hand, the Ecolab-Bidene and on the other hand, the BD Chloroprep solution. Summing up, the dashboard and our prospective snapshot data were comparable. And the dashboard, in addition, helped us to identify important trends and to improve practice with, for example, a change in the skin antiseptic solutions at the two centers. And we furthermore introduced a photo at discharge and launched our new surgical site infection app in October 2020. In the next step, we will report on our prospective re-evaluation of surgical site infections. Thank you very much for your attention.
Joe?
Yes, hi. I think we've got a question from Chris. Do you want to go ahead and ask your question, Chris?
Nora, thank you. Nora, the incidence of infection is very low. I mean, most thoracic departments are going to see, what, 1 infection, 2 infections a year. How are you going to sell this to the thoracic community to get them to engage in a website such as this?
So I know that's a problem, or kind of a problem, because the rate is very low, but we still want to reduce the rate of infections even further, which is why we launched that app and why we're going to monitor our infection rate and see if we can pick up those infections quite early and probably even prevent any infection.
One of the things that I've personally found that has made a vast difference when I was doing cardiac surgery, and also makes a big difference in my wound infection rate regarding thoracic surgery, is the number of layers and the type of material used in wound closure. So I increased the number of fat layers in cardiac surgery and had a skin closure below the skin layer, and I've got 2 fat layers of closure, and things like that. None of that's ever evaluated in methods of assessment for reasons of wound infection. Can your website be modified to do that?
I can address that, and in addition, coming to your point, like that we have a bit more wound infections after cardiac surgery. We just opened that program up for cardiac surgery as well, to probably a bit like move on to the cardiac side and to have some help from the dashboard or from the app for the cardiac wound infections as well. Unfortunately, we didn't look at the wound closures in our study.
One last question, if you have time. I was thinking along similar lines. Mr. McManus has asked, with Vats surgery, discharges are happening quite soon, and I often see these patients in clinic saying that, oh, I had a wound infection. So are we missing a subsection of patients with wound infections?
So we, with our app, we encourage the patients to upload a photo of their wound, like 7 days post discharge and 4 weeks post discharge, sometimes even a bit later when the wound is not or is a bit dodgy. So we hope we won't miss any late wound infections.
Okay. And one last question, if you have time, again from Kieran McManus. Does sending patients home with chest drain in situ increase wound infection problems?
We will monitor that. That's one part of our program as well, because we can ask the patients to upload, for example, videos of their, so for seeing about air leak and checking the wounds as well when they were discharged with the chest drains. I think that's for the future, for like having chest drain clinics, probably virtually and with the app, to ask the patients to upload videos to prevent wound infections with drains.
Good, very good. Thank you for your excellent presentation. I think it's something we should look into nationwide. We'll move on to the next topic.
Sure. So thank you. So the next presentation is going to be done by Scott Lawson. It's actually from Vats, submitted by Ms. Baranowska, but unfortunately she's double booked. So Scott Lawson from Pulmonix will be presenting. It's about what happens when a lung volume reduction service is offered to a new referral practice. And I suspect, looking at the abstract, that this was designed before the national commissioning and before the meeting was cancelled last year. So go ahead, Scott. Thank you.
Hello, my name is Scott Lawson and I'm UK and Ireland National Sales Manager for Pulmonix, which supply Zephyr endobronchial valves for lung volume reduction in patients that suffer with severe emphysema. This talk outlines what happens when a comprehensive lung volume reduction service is offered to a new referral practice. This talk also highlights the benefits of a collaborative approach between clinician and industry, which by working together created a forum for clinical discussion and helped facilitate the creation of a referral treatment pathway. A commercial approach to the activities was taken rather than just blind science, with soft, not hard medical fact combined with practical content. There were 5 steps by which we established the Vats lung volume reduction practice in Essex. Step 1 was to communicate. 2, accessible. 3, selection. 4, feedback. And 5, local. Step 1, communicate. The important part is that you get out there and spread the word and look for the work, as the work will not come to you. I arranged for face-to-face educational meetings using my contacts in 5 units where no clear referral pathway had been established. Mr. David Waller and I then gave presentations to and had discussions with each of the respective respiratory departments. We kept it simple by presenting the evidence in a clear form, not to bamboozle them, and we used real-life cases and asked attendees to bring cases with them for discussion. We kept the selection criteria broad, especially at first, to get the message out there that we wanted hyperinflated patients, whilst being conscious not to create too many barriers for referral or for the physicians to filter at source and only cherry pick the very best patients. It's very important that we are to be accessible and efficient. Each centre was provided with a single referral pro forma, which included some of the selection criteria. A single NHS.net email address was given as a referral source. The surgeon coordinated the referrals, and when the referrals were received, the CT scans were run to obtain a Stratix report, which is provided by Pulmonx free of charge and helps with the selection process. I'll come to that shortly. All patients were discussed at the next MDT and seen in clinic promptly, and dedicated regular theatre time was allocated and still is allocated with 1 to 2 slots per month. Patients were not put onto a waiting list. It was felt that if BARTs were willing to take on the referrals, they must also be willing to dedicate the theatre time in order to treat them. NHS England has recently commissioned lung volume reduction, so that coupled with a favourable tariff reimbursement means the procedure is fully covered for theatre time and resources. So step 3, be selective. This flow diagram can be broken down essentially into 4 steps. The first step being that they must fit the inclusion criteria, essentially through having big lungs. They then must have their targets assessed through a Stratix report and a perfusion scan, which will identify if there is clear targets or not. Then collateral ventilation, so step 3, collateral ventilation must be assessed through the use again of Stratix and Chartis. And then going on to evaluating at step 4 risk through the Glenfield score. And of the patient cohort, 75% were deemed low risk. So patients would be offered unilateral LVRS if they had collateral ventilation, so if they had incomplete fissures with no targets. So if they had homogeneous disease with no clear targets and had no complete fissure, they would be offered unilateral LVRS, but only if they fell into the low risk group. And it's advisable to avoid high risk cases when you first start. I mentioned the Stratix report that can be seen here in the top left hand corner. So when a high resolution CT scan, so that a CT scan with slice thickness less than 1.5 millimeters, a report can be produced and supplied the following day, which looks at destruction scoring. So looks at areas of emphysema, and that's represented by shading. So the darker the shading, the more destruction in the lobe and the more emphysematous tissue. So you can see on the scan there that it's predominantly lower lobe and middle lobe on the right-hand side. We also look at fissure completeness. It's the first line in assessing if there's going to be collateral ventilation or not, so any communication between the lobes. And what you can't see there, it also supplies inspiratory volume measures, which help again in the decision-making process for when you have multiple targets. Essentially, through this procedure, we're treating hyperinflation. We're not treating the emphysema. We're treating the hyperinflation to get symptomatic benefit. So having that inspiratory volume is a useful tool to have. Endobronchial valves are used for bronchoscopic lung volume reduction. These are nitinol, so titanium and nickel alloy wrapped in silicon, and you can see a duckbill mouth there that opens on expiration and closes on inspiration. And when we place these segmentally or subsegmentally to get a full lobar occlusion, the patient will, over time, slowly deflate the lobe until they have atelectasis and symptomatic benefit. The top right there is Vats lung volume reduction surgery. And as you can see in the bottom is Vats LVRS with the use of the ICG there, which helps to identify perfused and non-perfused lung tissue to be super selective on the sections of tissue that we remove for a better outcome. Step 4 is give feedback, particularly explaining early on as to the reasons why we do not treat some of these patients, so why they might have been rejected. It's very important to feed that back very early on, as well as being specific of why LVRS or why valves have been chosen in patients that have been selected for treatment. So once the face-to-face meetings had been held, we held 2 further follow-up meetings, and they were held in a central location in Essex, in this case Chelmsford. And that was because it was ease of travel for all of the centres. These follow-up meetings were held 1 year post the initial meetings, and a second round of feedback meetings were held after 100 referrals. We showed the breakdown of the referrals in the region in the hope that it would stimulate the others to refer. Their own patients were actually fed back to them and the results shown to really cement the benefit that this is having to their patients locally. The two pie charts show that Colchester and Southend took on the collaboration more strongly than other centres, and there was variable uptake and some physicians taking on the process better than others. It's worthy to note that the centres that referred a lot of cases also sent in a lot of unsuitable cases, as well as suitable cases, and it was not a case of one or two hospitals only sending unsuitable cases. It was evenly distributed throughout. So step 5 was to make it local. So once these meetings had taken place and a strong pathway was established, the next step was to take it local by establishing a lung volume reduction clinic in which the patients could attend and travel much less. There was an increased use of local investigations, which led to good relationships with local referring physicians and was good PR. Furthermore, a local MDT has now been established, which has led to increased education and increased referrals. So the results over a three-year period between September 17 and October of last year, 145 patients were referred, which is really quite impressive. And of those, less than 10% were deemed unsuitable. 18 patients declined treatment. A couple of the unsuitable patients also were not hyperinflated enough, and some had cardiac disease. And of the 18 that declined treatment, some was due to travel and they didn't want to come into London, and some was that they did not want to take the risk when falling outside of the low risk group in using the Glenfield score. Some also deferred treatment for when the symptoms worsened. So essentially, those that declined was due to travel or they didn't feel their symptoms were bad enough currently to warrant the treatment. So there was slightly more than half had surgery. However, it must be noted that the surgical team's preference is to perform the procedure bronchoscopically with Cephalon bronchial valve. And Vats was involved in the SLED trial, which is a trial comparing valves against surgery for lung volume reduction. And some patients went into the LVRS arm because of that. In general, if the patients had no collateral ventilation, so if they had a complete fissure, the first line treatment was Zephyr valves. In those patients that received LVRS, it was more than likely that they had collateral ventilation, so they had incomplete fissures. Of the patients that received endobronchial valves, 1 in 3 had a pneumothorax, which is slightly higher than the published data, which is a result of the challenging patient population seen at Vats from Essex. So in conclusion, there was a great demand for lung volume reduction in respiratory practice. There was enthusiasm for greater involvement in selection by the MDT. There was a variable response among units and physicians. There were very few inappropriate referrals, with a small majority suitable for LVRS and not bronchoscopic lung volume reduction. And very, very importantly, that the work won't come to you. You must get out there, spread the word, and make the initial move and go out and get the work. Thank you.
You're muted.
Am I?
Yeah.
I think I'm okay. Thank you, Scott, for that excellent presentation. And Pulmonx has certainly played a great role over the years in bringing lung volume reduction and both surgery and valves, to the stage where we have got national commissioning now across the country. And you're quite right. I think there is a lot of work which is, left to be discovered still around the country. It's relatively unexplored and undeveloped lung volume reduction, and I'm sure the next few years national commissioning is going to help quite a lot, develop many other centers who are going to find it, developing teams, which is very important, as you pointed out. Can I ask you, how did COVID, the last year, national commissioning came out in the middle of COVID, how did that affect, your team or the team which you helped develop in London with David Waller and Relitza?
I think first of all, obviously all lists were cancelled. Capacity was a big issue at the hospital. But I think once we started to come out the other side of the initial peak, I think pulmonary rehab was particularly a main issue on the working up with these patients, spacing out the also the lung function testing. has become very difficult to actually get the patients through the pathway. I do believe that it's starting to alleviate somewhat now, but in other centres there's quite a bit of backlog with the PR. So I think it's just the case of working them up and re-establishing the MDTs. Now we've came out with the side of the wave has been the main challenge.
Sure, no, thank you. I don't know if any of my co-chairs have any other questions. We certainly don't seem to have any audience questions. Anybody, any of my colleagues?
I think it's important to show the model, this model that you've described, Scott, of getting engagement from the MDTs and actually growing the practice is important, because I think there is a great deal of work there which isn't being done. And part of it perhaps been in the past where your fingers have been burnt with doing high-risk stuff that is not going to get benefit. But the pathway you've shown, I think, is a really good model to emulate. How can we all start to, pick this up? Is it just so? Where do you suggest we should start?
Well, I sort of see the lung volume reduction going down the similar sort of lines as you have with your lung cancer MDT. So the relationship the thoracic surgeons have with their referring physicians in the lung cancer department, I think if we can replicate those MDTs, within the region in relation to severe emphysema and the management of hyperinflation, I think that would be a great model to sort of follow. And I think it's really just creating relationships between the surgeon and the referral physicians in the network, like I said, and replicating the efforts of lung cancer.
So thank you, Scott. I've got some audience questions. So Jay Nandi asks, what criteria determine whether RATS or Vats was used? He's also got a second question, which is what proportion of valves were inserted by respiratory physicians? I think this was a surgical team, wasn't it?
So I can answer the second question, and it's solely done by the surgical team. So the patient was consented prior to coming into the theatre for both valves and surgery. And I think that's the important thing for the patient, is they're going to wake up having received a procedure. So they would have the Chartis assessment, and if they have a complete fissure, they receive valves. And if they have an incomplete fissure, they would have lung volume reduction surgery, of which the break between LVRS and, between robotic and Vats, I can't answer. I need to pass that question over to Ms. Baranowski.
Sure. Adrian's got a question, Adrian Marchbank, and I don't know whether you can answer, but he's asking, did you target primary care as well? Many patients don't get to respiratory clinics, but there are COPD nurses in primary care.
That's something that we're now looking to address. We don't have the capacity in the sales team at Pulmonx to do, to really delve into primary care. So we've sort of highlighted pulmonary rehab being the key factor. A paper came out of the Brompton recently that showed that between 5 and 18% of patients that finish pulmonary rehab are eligible for a potential lung volume reduction procedure, but they're not finding their way to an MDT. So our focus now is to educate the pulmonary rehab and use them as the sort of middleman to get them on the pathway to somebody's MDT and treatment.
Sure. Lalitza, you just come on. Did you want to answer Jay's other question?
I've just presented our talk on robotic lung volume reduction. Actually, we now tend to do most of the patient robotically, as we found that there is a huge benefit of the ICG as well as the robotic staplers. And I think that's in the future, unless it's part of a trial, I think we'll go more to switch our surgical practice to robotic compared to Vats.
Sure. Can I let me just quickly check whether there are any other questions waiting. There aren't any. So one final question, please, Relitza. So when you compare, one of the advantages of doing RATS is the endo-wrist, isn't it? Do you find that with air trapping and other things, it helps much better than Vats, doing it RATS?
The new generation of the robotic stapler is actually the Sureform staplers, and they can give you feedback of the thickness of the tissue, and that's what is the main benefit, because actually the stapler is partially automatically stopping and gives you real-time feedback of the tissue thickness. And I think this might be the big difference because it's much more precise stapling compared to the Vats staplers. The standard staplers we use for video assisted.
Sure, no, thank you very much. And I'd like to invite my co-chair, Chris, to introduce the next presentation, please.
Great. So I'm really pleased to invite Jonathan Edwards. As we know, John has been a really front runner in the management of chest wall injuries, and he ran the first course for training for chest wall fixation. And he's also part of the organising committee for Chest Wall Injury Society. So Jonathan's taken quite an important role in leading UK on the management of chest wall trauma, and he's made a big difference there. Now, he is having problems, I think, with his internet. John, are you there? Jonathan, are you there? Yeah, just coming in now. Okay. So all yours, John. Take care.
Hello, my name is John Edwards, thoracic surgeon in Sheffield, and I've been tasked with the talk Surgical Stabilisation of Rib Fractures. These are my disclosures. There's far too much to address in 15 minutes, but I do hope to touch on these aspects. Students of thoracic surgery textbooks will know of the excellent publication by Pond de Bro, the first professor of thoracic surgery in Birmingham. This is a textbook that I covet. He describes surgical stabilization of the chest in this book thus: and yet, at least when I started training in thoracic surgery 25 years ago in Birmingham, surgical stabilization of rib fractures was completely absent from our practice and seemed to have been forgotten. For historical notes, I commend this review by my Dutch colleague, Michael Bemmelman. He tells tales of the iron lung, of coat hangers, of bullet forceps. Moving on to K-wires for the management of the unstable chest. Yet when we presented at this meeting in 2009, our first 7 cases of surgical stabilization of rib fractures with plates and screws, we were dismissed, with some discussants suggesting that it would never catch on. The ears of the younger generation pricked up, however. Indeed, as this had not been performed before in the NHS, our trust implemented the dreaded 10-point plan, which involved informing NICE of our plans to perform the surgery. This resulted in a thorough appraisal of the then evidence by an Interventional Procedures Advisory Committee, which resulted in the issue of NICE guidance. The guidance simply stated that we could perform surgical stabilization of rib fractures as long as we were sensible and audited our results. Around this time, the introduction of the major trauma centres in England brought thoracic surgeons and orthopaedic surgeons together to discuss optimisation and integrated care for the severely injured patient. When we surveyed colleagues in 2014 and again in 2019, we noted that we were not always co-located with the major trauma centre emergency department. So, as we started to provide surgical stabilization of rib fractures on a national basis, different models of service provision naturally followed, as you can see here. The initial growth of cases was exponential as units set up new programs. But note the doubling of the involvement of the orthopedic and trauma surgeons in service provision 5 years later, from 7 to 15 units. From 2015 onwards, SSRF cases have stabilised in the UK, although the total experience varies dramatically between different centres, as you can see here, as did the number of cases performed on an annual basis. To understand variation, we need to know the denominator, however, and that is clearly important. The Trauma Audit Research Network helps provide these answers. And Helen Ingo and colleagues have provided the first in-depth analysis of the Tarn chest wall injury dataset in this publication last year. This is a complex presentation. But as you can see here in the middle column, just 2% of cases underwent surgical stabilization of rib fractures in that year. Just 8% of cases were admitted by the cardiothoracic specialties, whereas half of all rib fracture patients are admitted to the non-major trauma center trauma units. 90% of surgical stabilization of rib fractures is performed in the major trauma centers. Pain control modalities were quite widespread. And Ms. Ingo here determines independent predictors of surgical stabilization of rib fractures in a multivariate model. However, in 2018, there was still lots of variation in SSRF. And why do we see that? Well, that's because there's a variation in opinions. In 2009, the well-recognized rib surgeon in the US, the trauma surgeon John Mayberry, surveyed opinion amongst his colleagues, both trauma and orthopedic surgeons and also thoracic surgeons. Through the European Society of Thoracic Surgeons and also the Chest Wall Injury Society, we're in the process of repeating John Mayberry's study. We've surveyed widely these aspects amongst orthopedic and trauma and also thoracic surgeons worldwide. We've looked at their experience, their knowledge, their opinions, the workload, the way that their service is provided, as well as indications for rib and sternal fracture fixation and how they assess patients and also their preferred techniques. And you can see here that there have been 4 separate surveys, including the US, UK, Brazilian, and Portuguese, which is currently underway, with wide, albeit thin in places, geographic representation. The work is ongoing, but these are the results so far. Suffice it to say that there'll be a lot of work ahead to analyze all the data that we've obtained. But here's an example of the potential value of understanding the practice of different units. Here is a diaphragm perforated by one amongst a series of displaced rib fractures, which was detected only by Vats. But when you ask surgeons in the UK, do you routinely perform Vats at the time of rib fixation? You can see that there is a significant difference between the thoracic surgeons and the trauma and orthopedic surgeons. Does this matter? Well, this survey, in conjunction with unit-specific TARN data, would be very interesting to see whether that variation in practice has clinical impact. But before we can consider the evidence, we need to be informed about rib fracture taxonomy, and we've undertaken a lot of work in this area. The AO Foundation and the Orthopedic and Trauma Association published recently an attempt at numeric coding of individual rib fractures. Although this has significant deficiencies in injury description, their intention was to allow coders the opportunity to assign a code for each rib. And you can see here the location as well. And the nature of the fracture line and fragmentation for each and every single rib fracture. They have also, for example, proposed a classification for injuries associated with the costo-vertebral junction, which is novel and quite useful. Under the auspices of the nascent Chest Wall Injury Society, we performed a Delphi exercise to generate consensus about taxonomy amongst published authors and trialists. And you can see here that we had 117 different responses go into this Delphi process from 18 countries on 5 different continents. And again, the results are quite complex, but I will summarize these. So you can see here that the categories of displacement, fracture line characterization, and interaction. Examples of undisplaced, offset, and displaced fractures are seen here, and separators of categories are according to the degree of cortical contact. We explored the definition of anatomical sectors around the chest wall, and the definition of flail chest and flail motion can also exist without the presence of a radiological flail segment. Definitions of an anterior flail chest were also explored. It's possible that agreeing radiological definitions for an anterior or sternal flail is very difficult, but it should be stated that the clinical assessment of paradoxical movements in these cases is extremely important. Furthermore, in Sheffield, we have examined the outcome predictors of the CWIS taxonomy in 539 patients with a total of 3,944 individually assessed rib fractures, demonstrating clinical relevance of the taxonomy. Our then medical student, Peter Clark, was honoured with the SCTS Society Thoracic Medal for this work. So how do we assess injury? Well, this is the form based on the CWIS taxonomy that we and now others use to characterize the injury. The nature of fractures is recorded in the appropriate box in the appropriate sector for the relevant rib. And then this allows precise communication between the different team members. So what I want to know, be it day or night, is that there are, in this case, 2 fracture series, as described here, and that there's overlap of the series creating a 4-segment displaced flail. And this is my proposed management plan. Of course, that's what I want to know as well. And so you can see here, as we describe this, there is the anterior fracture series, here is the lateral fracture series, and there is the overlap providing the 4-segment flail. Note the grey boxes. We've also addressed taxonomy of injuries to the costal cartilages, and particularly my pet topic is of injuries to the costal margin, the slightly darker grey, as you can see here. And this we have published in the European Journal a couple of years ago. And in doing so, we use sequential segmental analysis of CT scans in order to determine a classification. This created specific categories of injury according to the status of the costal margin, the diaphragm, and the intercostal muscles. This then allowed precise guidance for surgical repair, again, part of my quest to change management of chest skeletal trauma from an art to a science. And with 35 cases of complex costal margin rupture now managed according to this algorithm, we're beginning to see the value of such an approach. And so to the science. The benefits described by the 5 published randomized controlled trials are well established. Tanaka, using Jude struts, demonstrated reduction in critical care utilization and return to work. Grzetzny's study of K-wires showed much the same, and also improved spirometry. Silvano Marasco's trial also demonstrated reduced critical care impact in surgical stabilization of rib fracture patients and improved health economics also. This is a presumed randomized controlled trial, but unfortunately is difficult to interpret. Finally, the Chest Wall Injury Society undertook a randomized controlled trial in non-flail patients, so-called CWIS non-flail, with curious methodology, whereby only 23 of the 110 enrolled patients were randomized, with the authors claiming benefits in the population of whole of the operative versus the non-operative patients, with both the observed and the randomized patients combined into groups. There are a number of current randomized controlled trials as well, and these are complete and unpublished studies, and then of course with the UK ORIF trial, which we'll come to momentarily. Dr. McKee's study has been presented in conference at the Orthopaedic Trauma Association, also demonstrating improvements in short-term outcomes with surgical stabilization of rib fractures. The Swedish study has been withdrawn, but ORIF, the ambitious British trial coordinated by the academic orthopaedic and trauma surgeons in Nottingham, is ongoing. This is now the biggest centre for the management of thoracic trauma in the country. Mortality and quality of life are the co-primary outcomes. And here you can see recruitment, which has been challenging and not quite to target even prior to the COVID pandemic. Currently, there are 11 centres open to recruitment, but more are being actively sought. Time for a quick pause. So when it comes to the indications for SSRF, what are they? Well, CWIS produced a very useful consensus statement based on a systematic review of all the literature relevant to surgical stabilization of rib fractures. And again, this is extremely useful reading. And the Eastern Association for the Surgery of Trauma guidelines are also recommended as a starting point. However, there are certainly indications beyond the Flail guideline proposed by Michael Bemelman and East. When one of my Smurf students tested the Bemelman guidelines, as you can see here, blinded to surgery outcome, we found high fidelity in our current practice. So in one slide, this guideline is believed to be very close to what we are doing currently in our centre and perhaps in other centres in the UK. You can see that the aspects of radiology in terms of the presence of a flail chest, the clinical aspects of that, and whether the number of rib fractures are important, as are clinical factors such as the ventilator dependency, the presence of chest wall deformity. In terms of techniques, well, there's a wide variety of techniques. There are many different types, as you can see here. We're all familiar, I suspect, with matrix rib, perhaps rib fix blue, and possibly Strakos as well. But you can see that there are a number of other different technologies for external plating of various different types. But also there's the thoracoscopic approach. The rib fix advantage endothoracic plates have yet to be introduced into Europe, but there has certainly attracted a great amount of interest in the United States. And finally, I commend you to the opportunities afforded by CWIS, which provides first-class education, research and mentorship for the aspiring pro-plater. The Chest Injury International Database is just one of the current initiatives of CWIS. So we have come a long way. We've learned a lot, but there's still lots of things that we don't know. And hopefully with better coordination of different groups, and CWIS provides a very important role in this, we'll be able to see where we are going in the future. And of course, I have to thank those without whom I would have not had the opportunity to be making this presentation. The 4 research fellows who contributed so much to the Sheffield Multiple Rib Fracture Study, and my very supportive colleagues.
Unmute myself. Jonathan, thanks for that excellent presentation. Really good piece of work. You've worked hard on this nationally and internationally, and you're making a great deal of progress. Jonathan, we've still got issues, haven't we, in tackling the subject. There is a great disbelief about the importance of SSRF and what's going to happen. Can I just ask you, we do know that there is a mortality of 25% associated, and this is repeated in all of the publications. Everyone that writes a paper about chest wall injury writes this, but yet in the conclusion, everyone concludes there is no difference on mortality. Do you think the ORIF study is going to tackle this question?
So the ORIF study, the primary outcomes for the study are firstly mortality and also quality of life, EQ5D. And the mortality statistical power was based on a service evaluation of their own institutional data, where they saw the mortality being reduced from, I think, 12% to 1.2 in propensity matched surgical patients. So one hopes that is going to be the case, but I do have some issues with the design of ORIF, and I'm not certain that we will be seeing such a dramatic reduction in length of life, dare I say it. Can I call it length of life? I think any intervention that we have in any branch of medicine has 2 outcomes: length of life, quality of life. And I think the length of life is I suspect they are hoping that we will see a reduction in mortality, but I suspect the stronger outcomes will be the quality of life and also the secondary outcomes in terms of critical care utilization, health economics and cost.
Thank you. We've got a question coming in from Jesus Izia de Lavina. If costal margin repair is required, how successful is a costal margin surgery?
So this I think, if anything, I was once known for mesothelioma surgery, but I think if anything, costal margin rupture is my favourite topic. at the current time. And we've had about 35 cases now that we have identified, and that's the most important thing. And I'm afraid that it was too quick to go through and hold and discuss the individual slides. But by creating a classification, it then allows you to look at our results systematically, and it also allows you to recognize by identifying and collating cases that there are deficiencies in the traditional methods of surgical management. So we were all familiar, those of us that did esophageal surgery, through a left thoracolaparotomy with deliberate cutting of the costal margin and then sewing everything up again at the end. And they seem to have no problem at all. But actually, when you look at the cases that you operate on, there's a high chance of failure, particularly with the chronic cases that are related to cough, vomit, retch. And they are often obese patients on steroids. And we've had failures, and that's where we came up with the concept of a double mesh repair, which we presented in the European Journal. I'll have to sort of pause in terms of the outcomes and the expanded series. It will be published in a book chapter fairly soon, which is under Dr. Adam Shearer.
We won't tap into that then.
Yeah, so it's going to be very interesting. It's a very interesting topic that I'm very happy to talk about whenever.
Yeah. Let me bring you to your classification, that lovely picture, and I think that's fabulous because you've included the cartilaginous, you've included the costal margin, you haven't included clavicular injury. You've got the vertebral as well, but you haven't included clavicular.
Yeah, the diagrams by the Orthopedic Trauma Association AO Foundation is for all skeletal trauma, so be it a little finger or a skull fracture and everything in between, and so that is primarily for coders to create a number associated with every fracture that is seen. Now, it is not, TARN have a slightly different classification system. It's certainly possible to pull out the rib fractures plus clavicle from TARN, as it is from your own data. If you ask your TARN data coordinator, they will be able to tell you. So if I look to my right, I can tell you that we've got 68 clavicle fractures amongst the patients that we've fixed over the years.
But don't you think we should get that included, because that's that affects the function of the chest?
So in terms of the clinical impact, I think we're still at the point at which we are that there aren't enough studies looking at when you've got there aren't enough studies that have classified the chest, the rib trauma, sufficiently clearly to then add the clavicle and then look at statistical analyses between the two. So the crucial thing there is that every publication uses slightly different classification. And unless we are talking the same language, the TNM staging of the chest wall, if you're just saying they've got fractures, they've got lung cancer, but you're not actually talking about the staging. And until you do so, it's very difficult to do these further sub-studies. When I asked Professor Olivier from Nottingham about the ORIS study a couple of weeks ago at CWIS, how are you going to classify the injuries? And it was met by a laugh of, a slightly nervous laugh. And I think the crucial thing is that all the studies, we need to try and homogenize our classification. And hence the CWIS terminology with its wide geographic representation is that is proposed. But it's only really through participation in the Chest Injuries International Database, which is free and easy for us to do, that we can then actually look properly prospectively at the clinical impact, just as we have done, for example, in the TNM staging of lung cancer through the ISLC.
Nilanjan, you wanted to ask?
Well, it's an audience question, really, and I think we're going to run out of time soon, but let's ask it anyway, because there's lunch next. Any role for totally Vats approach for some rib fractures, John?
So there is a system that is in clinical use in the US, and one of the advantages of CWIS is that we can, people post their cases, and so I've seen a lot of cases presented with people using the RibFix Advantage system. It's not yet available in Europe, and when it will be, some of us, I'm sure, will be keen to teach on it. Conflict of interest. I have taught in animals on it. I think there are some advantages, and but I'm not yet. With jury is out yet in terms of the its particular place compared to other external plating systems.
Kieran's got a question here, John. SSRF has exposed the inadequate treatment of diaphragmatic injuries, clotted hemothoraces, lung, etc. Is CWIS doing any work on these factors?
So again, the chest wall injuries, the Chest Injuries International Database does have these data being included. So in terms of prospective registry study, yes, that's coming. The largest studies that we have are reliant on the coders. So if we go into Tarn, there I say it, Helen Ingo's paper is the only paper yet that has come out from Tarn, looking at the chest wall fields that were agreed between thoracic and orthopedic surgeons. So some of these things are being looked at. But in terms of the optimal management, I mean, again, it does take institutional or registry data, ideally, an analysis of that in order to look at those outcomes, look at the variation. Because I think we've learned a lot in cardiac and thoracic surgery about variation in practice, and I think to understand the variation in rib fracture management is going to be really important to improving those outcomes.
John, that's brilliant. Thanks. I think we're running out of time. I'd like you to thank you and all of the presenters for their time. Thank you to my co-chairs for this. Before I do close, John, I think there's a need for a conference on chest wall trauma in UK so that we can get a better understanding. Perhaps we ought to work on this. There's a lot of work to be done yet. So thank you very much, everyone. I think we will call this morning session to a halt. We are meeting again at 1:30. And there's also a request that we engage in the A to Z of the industry this afternoon. I think it's 5:55. And also, can everyone please do visit the industry sites as they provide great support to us in the SCTS. Thanks very much. Thanks to all my co-chairs. Lovely to meet you today.
Thank you. Thank you, everyone.
Thanks for the discussion. At least we got there. That's great.